Evening. It's 5 minutes past 6, so I think we should start. This is one of the series of short seminars in spine surgery which we are holding before the second wave struck us. We were holding about once every 2 months. And the concept of this seminar is that we have related people from the spine surgeon perspective. We've had a neurosurgeon, we have had inputs from an oncologist, now we are going to have an input from a dermatologist. Rheumatic diseases in the collagen vascular diseases are very often found in spine practice. So for our listeners, this would be very benefit because most of the patients you see in the clinics will have some relationship with pathology. Basic understanding of seronegative to a long way understanding the behavior of these various collagen vascular diseases. To introduce our speaker today, Pathophysiology is relatively a newcomer in this city of joy. I'm sure it's going to spread many joys amongst the rheumatology patients. He is a graduate from Clinico-radiological Medical College. He passed out in 1999, and from 2000 to 2005 he was in, and 2006 he sailed abroad. He was there for about more than 8 years, trained in general medicine, and then he joined the rheumatology practice. And he became a consultant rheumatologist in London. He came back in 2018. By 2016, 17, he was kicked off the technical part. He was honorary teacher in the University of Leicester, and obviously he has had many contributions. So after coming back, he's joined Apollo Clinical Hospital, and along with that, he also sees patients in Pathophysiology my proud privilege to present Dr. Pathophysiology class. I'm sure it's going to make this half an hour, 45 minutes. After his talk, which is actually recorded on Zoom, we will be streaming live publicly. There will be a certain question answer session, and one of our fellows is going to present a case, which is my practice. We're all surgeons here, so we all actually ultimately end the day with some surgical stuff. And so the surgical stuff sort of hinders our goals of further researching the scenario of anatomy and spine practice. I welcome Dr. Pathophysiology.
Well, thank you, Shomadida, for the very nice introduction. Can you hear me? Should I?
Take off your mask. Otherwise, it's very stifling.
Okay.
Very difficult for understanding.
I'm used to now using phone. Okay. Right. So, thank you, Shomadida, for the invitation. I'm going to speak on a very interesting topic, which is seronegative spondyloarthropathy. Just few breakdowns, which is pathophysiology, clinico-radiological evaluation, and the management. For the pathophysiology, I'm not going to delve in very detail because that's been boring, but I'll give you some reference. You can have a read back through as well. I think this got it has to be taken from the machine. Because this box is not showing up in here. This is here. Let me drop it. So that's fine. That's my first slide. So just a bit of a background about the chronic back pain, which we normally all deal with. So it's a very common presentation. It comes to neurologists, orthopedics, spine surgeons, rheumatologists. The prevalence of inflammatory back pain in UK is around 3%, according to Callin's criteria, which I'm going to come in a minute. We don't have proper data in India, but in the South Asian countries or Asia Pacific countries, the prevalence is around 0.01 to 0.49%. In terms of diagnosis of inflammatory back pain, there has been a significant delay. Even in UK, which is quite an organized center, is around 8 to 11 years. Now, what are the sources of back pain? Mechanical back pain, which you all know more than me, is a degenerative spinal disease, spinal stenosis, osteoporosis, fragility fracture, spondylolisthesis, etc. What we are going to discuss is the inflammatory back pain today, bit more details in coming slides. But what we shouldn't forget is the red flag signs, like the aortic aneurysms, infections, abscess, tuberculosis, malignancy, etc. So what are spondyloarthropathies? So they belong to a group of disease which present similar kind of manifestations. The group of disease means ankylosing spondylitis, psoriatic arthritis, undifferentiated, where all the with vague presentation, but they have MRI finds of sacroiliitis. Juvenile spondyloarthropathy when patients are less than 16 years. Inflammatory bowel disease, rheumatoid arthritis, and reactive arthritis. They all pretty much present in a similar way, which is sacroiliitis, like inflammatory back pain. They can have peripheral arthritis. They have enthesitis, that means inflammation of the ligaments or tendons. Dactylitis, which is swelling of the digits, and eye involvement. So they can be seronegative or seropositive. So if they're seropositive, that means HLA-B27 is positive, or suppose you have psoriatic arthritis or rheumatoid spectrum, other antibodies are positive, then you label as seropositive. And if it's a negative, that means all these antibody screens are negative, then, but the clinical present is pretty much same. But when you have HLA-B27 positive, the chance of getting inflammatory back pain or spinal involvement is much higher. So this is the concept of spondyloarthritis. It's basically, we can divide into peripheral symptoms and axial symptoms. So axial symptoms are mainly angstpond and non-radiographic axial SPA. I'm coming to in a minute. And the peripheral arthritis, mainly reactive arthritis, psoriatic arthritis, inflammatory bowel disease, related arthritis, undifferentiated. But to be honest, very difficult to differentiate in between two. There's quite a bit of overlap. So if you look at this slide, I mean, so we can see the cursor here. If you look at psoriatic arthritis, you can see most of them have axial, peripheral symptoms, but around 30% of patients can have spondyloarthropathy as well. Similarly, in inflammatory bowel disease, most of them can have peripheral arthritis, but certain around 15-20% they can have axial involvement, like sacroiliitis, spondyloarthritis. And even you can see, even in non-radiographic or radiographic spondyloarthritis, certain percentage of patients can have peripheral disease. So this is, in a way, is an advance of angstpond patients, where you can see quite a bit of spinal stiffness. But it's important to note the flexion deformity of the spine and the knees. And this is, in the present context, a patient in a COVID scenario, which I've seen some while ago, just a few weeks ago, actually. And this is the presentation. In this patient is quite a curved posture. You can see, we can't strip the patient, we didn't strip the patient, but a bit of reflection of the hip joint and knee as well. So not only the arthritis, like the joints or the spine, they have multiple extra-articular manifestations. They can present with enthesitis, around 39 to around 50% of them can have different ligament or tendon involvement, like Achilles tendinitis. They can have peripatellar tendinitis, tennis elbow, plantar fasciitis. They can have large joint, even small joint arthritis as well. Dactylitis is prevalent mainly in patients with psoriasis. Eye involvement is quite common, is very often missed, especially in the child, like young population. Psoriasis is prevalent around 10%, and they can also have IBD, like inflammatory bowel disease. So look for the skin, look for the nails, take proper history about the inflammatory bowel disease, or else you're likely to miss many things. So how do you diagnose? It's basically a conglomeration of various things, like proper history taking, investigations, imaging, X-rays and MRIs, and response to anti-inflammatories. That sometimes can give you some clues as well. These are all assessment of Angstpond Society workup group slides. So this is very standardized. So how do you diagnose inflammatory back pain? There are several criteria, Cullen's criteria, Root-Wallis criteria, IBP expert criteria, but very well established and accepted criteria is the ASAS criteria. So someone with inflammatory back pain, when they follow this following practice, age is young patients, less than 40 years, insidious onset, that means very slow buildup. If it is sudden pain, acute pain, then it's more of a spinal injury, fracture, disc problems. The pain gets improved with exercise, and they get worse with rest. And the nocturnal pains, pain is worse at night time. And when patient is gets up, the pain settles down. So if you have 4 out of these 5 criteria, it's quite sensitive, which is around 79%, nearly 80%, and specificity around 72%. So how do you diagnose Angstpond or spondyloarthropathy? So Roman criteria was proposed in 1963. Then it was developed. The New York's criteria came around 1966, which was modified in 1984. But the problem, what you can see is all these patients have chronic back pain. But if you look at these criteria, there is limitation of motion of the spine, limitation of chest expansion, radiological evidence of sacroiliitis, and the definite AS when you have radiological criteria associated with one clinical criteria. So if you fulfill this criteria, patient definitely has AS. There's no doubt about it. But where is the problem? Any suggestions? Any ideas? So why is it preferred not to follow this criteria? Yeah, exactly. Because this is already advanced. Patients have very stiff spine, very limited expansion. So we have missed the bus. So we have to diagnose these patients very early on before they develop all the symptoms. Once they develop the symptoms, you can't go back. This patient already has a stiff spine or fused spine probably. Yeah, so this is the concept has come around from 2000 only. So this is a radiographic and non-radiographic axial spur. If you see the radiographic, that means patient has X-ray changes. So you have bony fusion, syndesmophytes, fusion of the kind of costochondral joints. So this is quite advanced. But the disease has started probably 10, 15 years up the line. So at this stage, patient will have symptoms. They'll have inflammatory back pain. They'll have MRI evidence of sacroiliitis or inflammatory disease, but they won't show up in the X-ray. So when you're quite convinced that patient has inflammatory back pain, it's better to get MRI rather than relying just on X-ray. And this phase will take years. It can take 10, 15, up to 20 years to develop your radiographic phase. So once this stage is reached, they have joint damage or syndesmophytes, you can't go backwards. So you can't reverse those bony changes. This is just a radiological representation. So at this stage, you can see quite a significant sacroiliitis, the edema around on the sacral side of the sacroiliac joint. But X-ray was normal at this stage. But at this stage, you can see quite a bit of sclerosis around the iliac side. And if it's not treated at this point, and this is not controlled, they can progress to radiographic stage, like quite a fused spine, which is called the bamboo spine. Now, this is the classification criteria proposed by ASAS group. If someone has inflammatory back pain or back pain more than 3 months, age is less than 45, there has been a difference in age amongst all these criteria, but this criteria has 2 arms. One is the clinical arm and one is the radiological arm. So this is the clinical arm. So clinical arm includes if someone is HLA-B27 positive and they have more than 2 SPA features. I'll come back to what is SPA features. And the radiological is if someone has sacroiliitis on MRI, so they need at least 1 features of SPA. So what are these SPA means? Spondyloarthropathy features? They have inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, which have discussed earlier. They can have just Crohn's disease. They have family history of spondyloarthropathy. So if someone has history of sacroiliitis evidence and there is a history of family history of spondyloarthropathy, patient doesn't need a HLA-B27 positive. So that is a spondyloarthropathy and you have to start treatment. And you can see the sensitivity and specificity of radiological arm is better than the clinical arm. Now, all the patients, what we normally deal with is very young, fairly young patient or middle-aged, from 20 till 40. But don't forget patients can present in an elderly age group. So I've got quite a few patients that are more than 60, they have inflammatory back pain, but we have to differentiate this axial spondyloarthropathy with something else. So in the ENHANCE study, up to 2.9% of the patients from 60 to 70, they have chronic IBP and they're all late onset axial SPA. But you have to be aware various other conditions like polymyalgia rheumatica, Paget's disease, fibromyalgia, osteo, they can all present in a similar way and they can present in a typical history of inflammatory back pain. So need to be careful. So there is a debate that non-radiographic spondyloarthropathy or radiographic spondyloarthropathy is a separate disease or is the same disease in the continuum. So a lot of debate is there, but there's some suggestions that this is completely 2 different diseases. There are many occasions where patient can remain in non-radiographic stage and they never develop a radiographic. But having said that, there's quite a bit of study and they have suggested in terms of clinical manifestation, whether in early stage or late stage or in radiographic, there's no obvious difference. So presentation is pretty much similar in terms of extraarticular manifestations, joint involvements, etc. Now, this is just a sacroiliitis, and pretty much you all know, so this is just a revision for you. So sacroiliitis could be diagnosed on MRI. This T1 is a fluid suppressed, basically it's a dark image on fluid, and STIR is a fat suppressed images, so the water or the fluid lights up. There's quite a bit of inflammation around the spine, and you can see just a bit of erosion in the spine as well in here. So this is anterior it's the Romanesque signs, which is the anterior spondylitis. You can see just corner lesions where the ligament is attached in all these pictures. This is the posterior spondylitis, the posterior caudal lesions. The spondylodiscitis, which is the Anderson's lesions. These are all inflammatory and they all qualify for anti-TNF therapy. But we all look at the spine like anterior lesions, posterior lesions, but many often we fail to look at the posterior element. Many times when you can't see anything, please look at the posterior element. Sometimes you might see some inflammation of the zygoepiphyseal joints or the posterior ligaments as well. Now, this is the mass classification criteria for research purpose for the radiology. I'm not going in details. Now, when we say seronegative spondyloarthropathy, so we should know what is the role of HLA-B27 and why is it negative sometimes and why is it positive most of the times. So there's a very strong association between HLA-B27 and ankylosing spondylitis. There are more than 200 subtypes, and only 2% of patients who are HLA-B27 positive, they are going to develop angspond. So rest of the patients can carry the gene, they won't never develop angspond in life. And when you're HLA positive, you have lower average age of onset of the disease, and there are more chance of eye disease as well. You can see there's various other diseases which can have HLA positive, not just the angspond. Even in psoriatic patients, HLA positive could be high, but in those patients where HLA is positive, there are more predilection for spinal involvement. So other like psoriatic arthritis, enteropathic arthritis, all have some association with HLA-B27. Now, this is just a cartoon. Which subtype is prevalent in which part of in the world, to be honest. So HLA 27.75 is more prevalent in African countries. In Asian countries is 0.04. In European countries, 0.02. So there is quite a bit of difference in the virulence among these subtypes. If it's 0.06, patient will never develop angspond. And if they have sharing of this SEC16A gene, so all patients will develop. This is a variation in penetration of the disease as well. Now, you're often asked this question, if I am positive, how much or what is the chance of my children getting a positive disease? So the chance of transmission for the next is around 10%. So if it's the same, if I have HLA-B27, I have 2% chance of developing the disease. And if I'm positive, I have the disease, chance of my children, like son or daughter, whoever, is around 10%. 90 out of 100, 90 patients won't develop the disease. But that is, you need to convey to the patient, or else they get very scared of that. So because of the gene sharing, monozygotic teens has more predilection for the disease compared to dizygotic. And for the same reason, for gene sharing, first-degree relatives are more prone to develop compared to second and third. If you're HLA positive, you're less chance of getting hepatitis C and HIV. And you can see many patients can develop ankylosing spondylitis, but they're HLA negative. So there is non-HLA related gene up to 15-20% of patients which can cause the disease, but they're not HLA-B27. So other genes could be ERAP1. I'm not going in detail. There are quite a few of them here. So if you want to read the Pathophysiology, this is a Nature's Review publication, and read through it. We don't know exactly how HLA-B27 causes the disease, but if you want, there's quite a bit of hypothesis there. Please spend some time. This is a very good article to read. So in terms of pathology, this is really important. When we see the spine, there are quite a few different types of pathogenesis going on. One is inflammation, which can causing pain, which is usually driven by TNF. They can have quite a significant erosion, which is usually driven by cathepsin K and MMP1, and they can have syndesmophyte formation, like a lot of osteophytes, syndesmophytes. Those are mainly the association between BNP, which is bone morphogenic protein, and warranted. I'm not going in details, that will become boring here. Now, let's talk more practical things. How do you deal with isolated sacroiliitis, unilateral sacroiliitis? In HLA-B27 negative patients, even so in HLA-B27 positive patients. So look for non-inflammatory causes. So patient might present to you in a typical inflammatory back pain, but they can have, when you do the scanning, they have unilateral. So spend some time, exclude the infection, like trauma, infection. Even in pregnant patient, that could be just a isolated sacroiliitis, like long distance runners, they can have isolated sacroiliitis as well. So if it's isolated sacroiliitis, inflammatory, you can treat with NSAIDs, a local sacroiliac joint infection. And other cause of sacroiliitis need to be considered, which is osteoarthritis, traumatic injury, pregnancy infection, which I've already discussed. Now, there are various diseases which can mimic as sacroiliitis. Few of them are sarcoidosis. They can present the back pain. Paget's disease, I think, Abrasa, we have quite a significant patient. I forgot to get the photos, so I couldn't present them. The patient had quite a fused and kind of osteo, kind of thickened bone, really. They were waiting for surgery now. Dish is a common differential. Osteitis condensus ilia is a differential, and brucella, which is quite rare. This is just a picture of dish. We have overflowing walk sign. So that means fusion of multiple joints, more than 3 or 4 joints, which happens mainly in the right side of the spine, because of the arterial pulsation, the calcification doesn't occur in the left side. This is just a osteitis condensus iliae. We have sclerosis of the iliac side of the sacroiliac joint, which is a benign disease. We just need pain control. So this is one more patient we have. This patient around 60s presented with back pain, and this was the X-rays. Any comment on the X-rays? Just shout out. Anyone you feel like. Is it normal, abnormal? So this is the sclerosis. So then we went on to do a bone scan, and this was confirmed as a Paget's disease. So basically, alphas was high, calcium was very high. I tried to get the pictures of our patient, but somehow I couldn't get it really. Now, again, this patient has got quite an eroded unilateral sacroiliac joint, and this was diagnosed with tuberculosis, sacroiliac joint tuberculosis. This patient had back pain, presented with different doctors, and finally diagnosed with sacral fracture, osteoporosis related. And any idea about this patient? Any suggestions? What could be the possibility? I've already clicked the wrong button anyway. So this is quite a massive lesion, and already sacroiliac joint is completely eroded. So multiple myeloma. So just think of other options when you're looking for unilateral surgery. There could be various differentials, not only just the ankylosing spondylitis. Now, any questions at this point? Any question you want to ask at this point?
So, as this is supposed to be interactive part, I don't know the first question.
Okay.
Why seronegative
Exercise?
Exercises relieve the pain, activities relieve the pain, and rest versus so why?
Now, I think there are various hypotheses about that. Suppose in rheumatoid arthritis, we mentioned early morning stiffness. So what happens when you're sleeping at night? Normally, there is some fluid secretion in the joint. So during nighttime, we're not moving moving our hands.
They don't get washed.
Exactly, the lymphatics are not draining in. So when you wake up, you normally start moving your hands, and they get all washed away. But when you have inflammation, so that means there is more secretion. So that means you're more stiff in the night. So when you start moving in the morning, and then all the fluids get, this is the easiest explanation to be honest. And that happens pretty much everywhere. So that because of inflammation, the fluid secretion, because of the cytokines involved, is much higher. So you need more time to get the fluids drained by the lymphatics, and when you start moving the joints.
That is the sacroiliac joint the lymphatics all around the.
Yeah. Probably, yeah, because the loss of cytokines, like all these TNFs are there, IL-17 is there, IL-23 is there, and they're drawing a lot of fluid. a lot of fluid. So it's quite stiff. When you start moving, the fluids get drained. Exactly. Muscle tendon junctions, all this tendinitis, they all get better. So that's the easiest explanation. There are various hypotheses like TNF related induction of various cytokines. Not going in details, but this is the easiest way to explain that. Any other questions from diagnosis, how to diagnose or management point of view? No. So I just proceed that. So how do you manage? So basically, you have to cover all the ends. Like smoking is detrimental for angst patients. Chronic smokers, yeah.
So you knew that there was a more than 10% removing for air. If you have 80% positive, there's 10% chance of removing from the air. So what about 5%?
It's a very variable across various ethnicity. So this is the European design. We don't have data. So we are imbibing data from the European US data. 10% chance.
And again, out of all A's, 90% are HIV positive, but 10% is negative A's. 30 people also not, I don't know if it stands good for today or not. 10% of these patients are females and 90% are males.
No, I think now this data is changing because all the European like Degerin Heights data, which is from the Europe, French, and German data, they see it for non-radiographic. For radiographic, that is advanced, probably the female is slightly higher than males are slightly higher than the females. In non-radiographic, there is no difference. And this data was taken from the recent ACR publication. So this 2% and 10%.
What about the disease progression? Is lower?
I think because probably what used to happen is detection rate was low in females. But if someone is inflammatory back pain and you do proper investigation, we get so many females who have sacroiliitis. Probably previously they were all only X-rays. And I think from 2019 onwards, we started doing the scans, MRI. And this difference is kind of getting faded now. I think that's the study I have shown. There is no obvious difference between non-radiographic, irrespective males and females. Just a second. These are all very good quality data. So there is no obvious difference in peripheral arthritis, dactylitis, eye involvement, both males and females.
Is it here to say irrespective of that?
Pretty much the same.
And progression, what are the factors which lead to progression? I mean, as I said twice this year, that AS is a huge spectrum. And one of them is to find a 25-year-old guy who had a couple of episodes of exercise. And then I started to live with the exercises where it doesn't progress anything. The other hand, you find a 35-year-old gentleman who is just touched down with really major certain quantities straight along.
No, one is the gene. So which gene is there? So if various subtypes have various degree of penetrance, that's one. It is gene sharing. Suppose you have HLA-02 and we have all those other genes like IRAP1 combination, then the penetrance is much higher. But if you're a smoker, if you have very lazy life, so those are things can contribute to it. But there is no predictive markers to say that this patient will develop severe disease and this patient won't. So we haven't got that. Gene study is going on. Suppose that gene, say SEC16 gene patients, they can have quite a severe and aggressive disease. So genetic study is still going on, but we haven't got the marker yet.
Do we do genetic studies yet?
Not yet.
Last question. I believe there are two types of estimations of age.
flow cytometry.
Yeah, flow cytometry. So
The PCR,
should we prescribe the flow cytometry?
I think PCR is more sensitive and specific. But compared,
What is the chance that flow cytometry negative PCR positive?
I think because the sensitivity and specificity is much higher in PCR, there's always a chance theoretically that there's a chance that flow cytometry could. But we have patients. We have seen patients. Patient has done HLA-B20 through flow cytometry 10 years ago, and when we have repeated it, it came back positive. We have few patients like this.
So we have data that this is the amount of flow cytometry that might be PCR.
I don't think so. I can look around.
The cost difference is quite a bit.
Quite a bit.
It's about 1.5 times more expensive.
Like Roy Trivedi, they do it flow cytometry even now.
No.
But if you write PCR, they send samples somewhere and get it done for you. But most of the lab, they have started doing PCR at the moment.
That actually does.
All the Quadra, all the standard labs, they do it. In Apollo is all PCR.
Sorry, you can go ahead.
No, that's fine.
I think we will discuss questions in a very process.
So I think so smoking. This one is it. So basically, one is a clinical arm, one is a radiological arm. So in clinical arm, you are incorporating HLA-B20, so putting more pressure on that. And if that is positive, then you have to have at least more than 2 SPA criteria. And radiological arm is more sensitive because you have evidence of active inflammation in the spine. So you need less criteria. That means one criteria should be okay. So what are the SPA criteria? Inflammatory back pain, which is very important. So if you have inflammatory back pain and if you have sacroiliitis, so that is probably angstpon. You don't need any more blood tests. Similar like rheumatoid arthritis. If you have proper history and if you fulfill the criteria, you don't need rheumatoid factor to start treatment. What we are aiming for is we have to diagnose this patient very early on so that they don't land up in damage later on. If you wait for another few months or few years because they have HLA negative, then you're probably wasting time. That's for patient's sake, to be honest. So the SPA features are inflammatory back pain, arthritis, enthesitis, anything like plantar fasciitis, peripatellar, tendinitis. Where do you go? Uveitis, that inflammatory eye disease, dactylitis, especially in psoriasis, Crohn's disease, good response to anti-inflammatories, family history, which is also very, very important. HLA-B20 we know anyway, elevated CRP, but don't put too much pressure on CRP. We have many patients with active disease, but CRP could be absolutely normal. All depends which pathway is involved. CRP is IL-17, IL-6 driven. So if that pathway is not involved, CRP would be normal. Simple as that. Is it okay? Right. So in terms of management, smoking cessation is very important. So if you have more than 10 pack years, that doubles the risk of retroprogression. Not only just the disease, there's a high risk of cardiovascular disease, high risk of stroke, and patients who continue to smoke, they become refractory to treatment, even with anti-TNFs, biological treatment. There's no restriction of diet whatsoever, so they can have what they want. Regular exercise, which is very, very important. And although there is no head-to-head trials, but it has shown patients who do regular exercises, they have a good quality of life. Now, this is important in terms of differentiating axial disease and peripheral disease. I have seen many prescriptions, probably we tend to do sometimes as well. When we diagnose patients with angstpon, we start sulfasalazine methotrexate. If you have axial disease, there is no evidence of enthesitis or dactylitis or arthritis. There is very poor evidence for sulfasalazine or methotrexate or any DMARDs. It doesn't really work on the spine. There are some studies from Velo and they have CMC Velo, and they have shown that long-term use of sulfasalazine may be helpful, but there is no strong evidence, to be honest. But I'll give you some guidelines, and they strongly recommended not to use DMARDs if it's just say axial disease. But if it's a peripheral disease, so how do you treat axial disease? So painkiller, regular physiotherapy, exercise, biological treatment. So anti-TNFs, IL-17 blockers, analgesics, and finally surgery is needed. For peripheral arthritis, we have loads of options, so which is DMARDs like sulfasalazine, methotrexate, just in inflammation or reduce inflammatory load